Welcome to the presentation on distributive shock secondary to anaphylaxis. This presentation will have a specific focus on New South Wales ambulance protocols and the treatments and management procedures they employ specific to both P1 and ICP levels of care. It will also include the pathophysiology and relative information taken from the literature. First of all, I've included the anaphylaxis protocol for New South Wales. Just for a bit of a reference guide, it goes through the main steps, inclusive of treatment options specific to patient symptoms. Obviously, we're looking at more specifically compound sodium lactate, glucagon, and adrenaline when in reference to distributive shock. I haven't focused so much on salbutamol, any antihistamines or hydrocortisone treatments, just so the focus is primarily on the distributive shock side of things. This here is the New South Wales Ambulance Medical Hyperperfusion protocol, which is more specific to the distributive shock and outlines the key signs listed there: tachypnea, poor brain perfusion, altered LOC, restlessness, agitation, confusion, poor skin perfusion, the things that we're looking for when we are considering a patient to be in shock, hypertensive, and in need of urgent treatment, which we'll go through later in the slides. So here we're going to talk about the pathophysiology of shock. And distributive shock specifically. Initially, I've just outlined shock. Shock is defined as an inadequate supply of oxygen to vital organs due to circulatory failure combined with an impaired oxygen utilization in the tissues. Distributive shock results from an inadequate supply of oxygen to vital organs by profound vasodilation, not necessarily from reduced intravascular volume or a deterioration in cardiac function. Those kind of shocks you'd be looking at more like hypovolemia in trauma situations or cardiogenic in MIs or things like that. So we're more specifically looking at shock, the distributive form, and that's known to happen in anaphylaxis. So in the presence of anaphylaxis, distributive shock results from the processes and underlying pathophysiology of the disease that ultimately leads to profound vasodilation. So we're going to look at the pathophysiology specifically of anaphylaxis. So anaphylaxis begins by an antigen entering the body, which results in the activation of mast cells and basophils through the activation of IgE. So antigens include things like food allergies, peanuts, bee stings from the environment. There's quite a large range of things that I'm sure most people are already aware of. So mast cells and basophils are responsible for the release of mediators, including histamine, which is normally the big one, tryptase, carboxypeptidase A, and proteoglycans. This then leads to the release of prostaglandins, leukotrienes, and platelet activating factor. So histamine being the most well-known one, stimulates vasodilation, increased vascular permeability, heart rate, and cardiac contractility. The release of prostaglandin results in bronchoconstriction, pulmonary and peripheral vasodilation. Leukotrienes leads to bronchoconstriction, increases vascular permeability, and promotes airway remodeling. Platelet activating factor is a potent bronchoconstrictor and increases vascular permeability. So in the essence of looking at why these kind of patients end up in distributive shock, it comes mainly from that peripheral vasodilation and the massive vasodilation that ultimately results in the hypotension and the vascular permeability and the leakage of that into the extracellular space. So distributive shock secondary to anaphylaxis is the overall result of the profound vasodilating effects the release of these mediators have, as well as a significant increase in vascular permeability, fluid shift, and depressed myocardial function, as I sort of said before, but summarized there. So here I've just included a sort of flowchart diagram to make that pathophysiology a bit clearer for those of you that like to have a visual image rather than just verbal or written down. So I think that is quite a good way of looking at it. So you got the initial contact with the allergen, the release of the IgE antibodies, the IgE on the IgE receptor, which is found on the mast cell, subsequent contact with the allergen, and then the histamine and inflammatory mediators are released. So it's quite a basic, I guess, diagram, but it makes it a little bit clearer. So let's talk about the clinical features. This is taken from the British Medical Journal. So things we're looking for in a patient that has or potentially has distributive shock secondary to anaphylaxis. We've got hypertension, which is the big one, tachycardia, skin changes, dyspnea, or in some cases tachypnea, hypothermia. Hypothermia, I guess you're looking at as a late sign of very poor peripheral perfusion, urticaria or rash, abdominal pain, vomiting, and diarrhea, which is found in anaphylactic patients at times, and altered GCS. So patients with reduced GCS is obviously a concerning sign. So physical exam. Importantly, airway. So we need to assess a patient's airway. Are they managing on their own? Do they need any? Do they need a Cadell? Do they need an NPA? Or are you concerned they might need intubation? Identifying any obvious swelling. Look at their breathing. What's their rest rate? Do they require ventilatory assistance or supplemental oxygen? Do they have signs of hypoxia? Do they have cyanosis? Have you auscultated? Is there a wheeze? Is there stridor? Circulation. So continual assessment of patient's circulation, basic heart rate, blood pressure, and capillary refill in all patients, obviously, but important to repeat blood pressure and heart rate, especially every 2 minutes in declining patients. Disability. Assess a patient's GCS. Do they have an altered level of consciousness? Is their GCS declining? Are you looking at the need for potential airway support in those kind of cases? And then the secondary survey, dependent on what you think the root cause of the anaphylaxis is, but you might be looking for rashes, urticaria, diaphoresis, signs of obvious bites or stings, edema. And then in patients with abdominal symptoms, do they have pain, tenderness, rigidity, or guarding? So I guess in terms of the physical exam, it can be specific to what the underlying anaphylactic cause is, what their symptoms are, and what needs further investigation. But I think in the instance of this, the main ones are airway, breathing, circulation, and disability, and that needs to constantly be reassessed whilst you're with the patient. We'll have a look at the pharmacology and the treatment. I've listed mainly the first line treatments of anaphylaxis and through to distributive shock. And I haven't focused on the second line things such as antihistamines and hydrocortisone. I focus mainly on adrenaline, fluid resuscitation, and glucagon. So we'll go through them. Adrenaline. So it's a first line treatment for anaphylaxis in all pre-hospital ambulance guidelines. So that's not just New South Wales. However, it's commonly read through the literature that epinephrine is underused in these patients, and that we should be more readily treating and managing patients with this and not delaying that treatment. So adrenaline is an alpha-1 and beta agonist. So the alpha-1 receptors induces vasoconstriction, which results in increases in systemic vascular resistance, blood pressure, cerebral and coronary blood flow. Beta-1 simulates increases in heart rate and myocardial contractility, resulting in increased cardiac output. And beta-2 simulates simulation provides bronchodilation and limits further mediator release. In terms of New South Wales protocols, I've just listed it there for further revision, but we have a 500 microgram IM dose, 1 in 1,000 for that, repeated every 5 minutes, as indicated. And following 4 doses, adrenaline infusion should be started, which is an ICP only skill. So if you can have an ICP there, so they can start that if it's required. That's a 1 in 10,000 diluted in 90 mils, and then administered. So fluids, depending on the service, but I know in New South Wales we treat with only Hartmann's, but is the major treatment second to epinephrine for anaphylaxis and distributive shock following that. So hypertension and anaphylaxis or patients with distributive shock should be treated with aggressive fluid resuscitation. And the literature suggests that they respond very well to this treatment. Often quite a large bolus is needed, so 1 to 2 litres. And you should, in most cases, see a good result from that. Again, it should be administered in line with epinephrine. And then glucagon. So this is not seen in all services, but is a New South Wales protocol. Glucagon is administration is indicated in patients who remain hypotensive after fluid resuscitation has been attempted. This is mostly seen in patients taking beta blockers, and that's listed in the protocol guidelines, protocol book for New South Wales. And it's in patients with refractory hypotension post-fluid administration, and the dose is 2 milligrams IV. So that's just in patients where they haven't responded well to fluid resuscitation. And as I said before, that's mostly seen in patients taking beta blockers. So relevant investigations, a thorough history for the patient is always a useful tool, especially in this situation. Where distributive shock secondary to anaphylaxis is suspected, paramedics should attempt to determine the antigen, allergen, or cause of the anaphylaxis. This will help guide paramedics' early diagnosis and initiation of appropriate treatment. Constant, as I said earlier, hemodynamic monitoring, so blood pressure, heart rate, just to identify trends and changes, and patient's oxygen saturation, so continual monitoring of that should be used. And so I've just listed a few relevant investigations, more for in-hospital, and what they use, just so we're aware. So in-hospital definitive analysis, they'll take a lactate, ABG, glucose, full blood count, urea, electrolytes, coagulation, and creatine protein. And then I've just talked about trip days here. So it's a specific in-hospital test to confirm diagnosis of an anaphylactic reaction. It's not used as an initial indicator, but later on. So tryptase is a major protein component of mast cell secretion, and during anaphylaxis, mast cell degranulation leads to markedly increased blood tryptase concentrations. So it's just a test that they use in hospital to help confirm the diagnosis. Transportation, decision making. Patients showing signs of distributive shock secondary to anaphylaxis should be rapidly transported to the closest appropriate hospital. Time on scene should be limited to initiating essential treatment, gaining IV access, and managing the patient's airway as required. A comprehensive pre-alert should be passed through the available channels to the emergency department, so teams are aware of patients' condition upon arrival, and just so that they're prepared. They might need an anaesthetist if they're concerned about the airway, or things like that. It can sort of get the ball rolling. I would, if possible, travel with 1 ICP, at the least in the back if they're available, and 1 paramedic. So there's 2 in the back to help with any decline in patients. And it's stated in the protocol book, don't let the patient stand or walk. They should be transported via stretcher or carried where appropriate, and keep them supine. So the leadership roles of ICP I felt is important to list here. Prioritizing and delegating appropriate roles for clinicians, including safe drug administration. So just ensuring that each clinician on scene has a role and knows their role and is doing that to the best of their ability. They should make sure they outline and ensure a clear plan for treatment has been established. And they should ensure they administer ICP level drug regimes, including adrenaline infusions, or ensure they're set up and ready to be administered when needed. Preparation for an appropriate airway should the patient decline. So ICP should make sure they're prepared for that, and ensure they make others aware of what the plan is for if that does happen. And following the job, obviously it can sometimes be quite a complex job. Just ensure that a debrief follows for education and paramedic growth. Here's my reference list that I've included. Thank you for listening to my presentation.